This video will cover blood glucose and weight regulation. The first set of learning objectives will cover blood glucose, including the pancreas, insulin, and glucagon. The second set of learning objectives will cover weight regulation, including leptin and ghrelin. The first learning objective is describe the expected changes in blood glucose and this concept of glucose homeostasis. So we're going to try to keep blood glucose steady and stable all day long. So if we look at blood glucose throughout the day, it will fluctuate. Especially when you're fasting and you haven't eaten, it will be lower. After a meal, because your food has carbs, your blood glucose will spike, but again, our body will bring it back down, maintaining blood glucose. So the stability of our blood glucose within this homeostatic range is glucose homeostasis. Glucose usually peaks after a meal and is lowest after you've been sleeping or fasting. High blood glucose is called hyperglycemia, and low blood glucose is called hypoglycemia. Hopefully, neither of those will occur if we're maintaining our blood glucose correctly. So when you eat food, most foods include carbohydrates. When those carbohydrates are digested down to simple sugars, the main one being glucose, that glucose then floods our bloodstream and circulates around the body. So why do we need glucose? Well, remember, our little cells like to use glucose in order to produce ATP. Glucose can be converted to pyruvate through glycolysis and make a tiny bit of ATP. Most of the time that pyruvate then will continue into the mitochondria to make even more ATP. So our little cells like glucose as a source to produce ATP. Just like all the other variables we've learned in class, blood glucose is going to be maintained in a homeostatic range. So throughout the course so far, we've talked about blood pressure and arterial blood gases, pH, and now we're going to add blood glucose to that homeostatic list. Blood glucose fluctuates quite a bit, but again, we keep it between a homeostatic range. So let's describe the role of hormones in the regulation of blood glucose. So how does the body keep blood glucose steady? It's going to involve two hormones, insulin and glucagon, as well as some helper hormones, growth hormone, epinephrine, and cortisol, which will help act with glucagon. The pancreas is the source of insulin and glucagon. So if we eat a meal, our blood glucose will spike and our blood glucose will get very high. So the hormone that we'll release in order to bring that back down is insulin. And so insulin will help bring our glucose back in the homeostatic range. If we're fasting and we haven't eaten in a long time, our blood glucose will drop, but glucagon, as well as cortisol, epinephrine, and growth hormone, all will help bring our blood glucose back into the homeostatic range. We're going to focus on the pancreatic enzymes, insulin and glucagon. These other hormones are made by glands we've learned, like the adrenal gland and the pituitary gland. So let's look at insulin and glucagon. So one thing to consider is that our pancreas, we've already learned its role in digestion, making bicarbonate and making digestive enzymes that can help in our food digestion. But now we're going to focus on some different cells. These little islands of cells are called the islets of Langerhans, or pancreatic islets. These little cells are going to be endocrine cells because they produce hormones that circulate around the body. We have two sets of cells, alpha cells and beta cells. They're all glucose sensors, so these little cells can sense how much glucose is in the body. If there's high levels of glucose, the beta cells will produce lots and lots of insulin. And that insulin then will diffuse into our bloodstream and circulate around our body. So when we have high blood glucose, we'll make lots of insulin in our pancreas. And that pancreas will then secrete the hormones into our bloodstream. If you ever have low glucose, you'll start secreting, instead of insulin, you'll secrete glucagon. And that glucagon then will circulate around the body. So again, these are pancreatic hormones that travel the body, and they're going to have important actions in regulating our blood glucose. So the alpha cells and the beta cells are blood glucose sensors, and they're going to actually make these hormones. So if we look and consider the targets, let's start with insulin first. So let's say you eat a meal, and that's going to cause an increase in your blood glucose. The little beta cells will sense that increased blood glucose, secrete insulin into your bloodstream, and now insulin is going to have important actions to reduce our blood glucose back down to normal. So we want to get our blood glucose back down, and that's insulin's job. It's going to signal to the liver, our fat, and our skeletal muscle cells. The actions of insulin will be to bring our blood glucose back down to normal. So let's look at the actions of insulin. In skeletal muscle, it's going to stimulate the uptake of glucose, and it's going to increase the use or storage of glucose. Again, we're pulling that glucose out of the blood and getting it into our skeletal muscle. In the fat cells, insulin will tell the fat cells to take up glucose from the bloodstream, but also to take up fat, so to store the fat and store the glucose. In the liver, insulin will have many actions. One is to decrease glucose production. So the liver can make new glucose, so we'll want to stop that. We'll also decrease glucose release from the liver because the liver has stored up glycogen, and so it can break that glycogen down and release it, but we'll want to stop that since we already have high glucose. And we'll want the liver to store the glucose, so increase glucose storage in the liver. So the actions now of insulin were to bring our blood glucose down. I wanted to remind you that the way cells in our body, like the liver and skeletal muscle, can store glucose is by chaining it together to create this long carbohydrate or polysaccharide called glycogen. So when our cells store glucose instead of using it, they'll actually chain it together as glycogen. The liver and skeletal muscle are examples of cells that can store glucose as glycogen. They can also break the glycogen down and then release that glucose and then can be used by the cells. Skeletal muscle will use the glucose, whereas the liver can actually release that glucose into the bloodstream for the rest of the body. So when we build glycogen, we call that glycogen synthesis. When we break the glycogen down, releasing the glucose, we call it glycogenolysis. It's a fancy way to say glycogen breakdown. So it's going to be important whether we have insulin or glucagon, whether we're going to be building glycogen or breaking it down. Okay, so let's look at an example where we haven't eaten in a long time and our blood glucose starts to fall because our cells are using it and it starts to decrease in our bloodstream. What will happen is the alpha cells will start releasing lots of glucagon hormone, which will then circulate around the body. The actions of glucagon will be to bring our blood glucose back up to normal. And the main target of glucagon will be the liver. So once glucagon targets and gets to the liver, it'll tell the little liver cells to increase glycogen breakdown or glycogenolysis, releasing that glucose then from the glycogen as it's broken down into the bloodstream. Glucagon will also tell those cells to make new glucose called gluconeogenesis. So things like amino acids can actually be converted into glucose, new glucose. Glucagon also tells the liver cells to make ketones. Ketones are made from fat metabolism, and the ketones can be thought of as an alternative fuel source. So instead of using glucose, we can actually have our cells use ketones. The problem with ketones is that they're acidic and they donate a hydrogen ion, so they can sometimes mess up the pH of your body, called ketoacidosis. But the actions of glucagon were to increase our blood glucose and even increase our blood ketones, all to keep our cells happy. Okay, so let's say you start eating a meal that will spike your blood glucose, and the response will be then to make more insulin. And the actions on our liver, muscle, and adipose tissue then will be to clear out and get rid of that glucose out of the bloodstream and into our cells, and our blood glucose will go back down towards normal. If you're sleeping or fasting and you haven't eaten in a long time, your blood glucose will start to decrease. And as it starts to decrease, our alpha cells in our pancreas will release glucagon. The actions of glucagon will primarily be the liver, and the liver's response will be to help bring our blood glucose back up. Other hormones will help glucagon, including epinephrine, cortisol, and growth hormone. And all of those help bring our blood glucose back up towards normal. So I just wanted to mention these helper hormones that all help increase blood glucose. In addition to glucagon, we have epinephrine, cortisol, and growth hormone. They're called counter-regulatory hormones because they oppose or have the opposite actions of insulin. So they're important to keep you from becoming hypoglycemic. Our next learning objective is to describe the consequences of insulin resistance and insulin deficiency. So either our body can't respond to insulin, or our body can't even make insulin, or not enough insulin. And so this is going to lead to a disease we've heard of called diabetes mellitus. So again, normally our blood glucose fluctuates but stays in the homeostatic range. In people with diabetes, they have hyperglycemia. Some might even have hyperglycemia without even eating, so it just depends on how bad your diabetes and your hyperglycemia is. But at any rate, your blood glucose is too high, either at rest or after you eat a meal. There are two types of diabetes, type 1 and type 2. Type 2 is the much more common type in the United States. So remember, little beta cells make insulin. In type 1 diabetes, it turns out that your cytotoxic T cells, and maybe even your antibodies, target these little beta cells for destruction. And without beta cells, you can no longer make insulin. And so these people are insulin deficient. So patients with type 1 diabetes have insulin deficiency due to an autoimmune attack on your beta cells. So patients with type 1 diabetes have no insulin, so they have to actually inject themselves with insulin, and it's usually timed around mealtime. Remember, after meals, our blood glucose levels will spike, but if you inject yourself with insulin, then the blood glucose will come back down to normal. In type 2 diabetes, it's interesting that their pancreas still makes insulin, and it is able to make insulin, but the body cells don't respond to insulin. So the little skeletal myocytes and the fat cells don't respond to the insulin, and so they don't take up glucose. That glucose stays in your bloodstream. Meanwhile, the liver actually releases more glucose into the bloodstream. So insulin's not doing its job, and your blood glucose goes higher and higher. The little pancreas may even make more insulin in order to get your body to respond, but it just doesn't work. Eventually, sometimes that little pancreas can poop out and it will stop making as much insulin. So type 2 diabetes mellitus is considered insulin resistance. The body doesn't respond to insulin, and it's almost as if insulin's not there. Eventually, some of those people can become insulin deficient if their pancreas stops working. So in type 2 diabetes, when the blood glucose spikes and goes up too high, eventually patients will be given pills either to increase insulin secretion or to increase insulin sensitivity of their body cells. If these medications don't work, then the patients have to start injecting themselves with insulin. The causes of type 2 diabetes are probably complex, but obesity and lack of exercise are associated with type 2 diabetes. It used to be called adult onset diabetes, but kids get it too, so we really just have to call it type 2 diabetes, and people at any age can get it. So we have this high blood glucose in diabetes mellitus, we have decreased insulin or insulin actions, and we have high glucagon levels. Again, all of that's causing our blood glucose to spike, as well as these ketones, and sometimes these high ketones can cause acidosis. So what's so bad about diabetes? Well, one is that a lot of people in the United States have diabetes, and even more are at risk for getting diabetes in the future. And so most of those people will have type 2 diabetes, and some of the health outcomes and the health effects of diabetes are pretty severe. Things like blindness, kidney failure, amputations of arms, legs, feet, and also heart attacks and stroke. So there's a lot of serious health problems that are brought about by having diabetes. What about hypoglycemia? So low blood glucose, when does that occur, and do we have to worry about that? Well, the good news is that hypoglycemia, or really low blood glucose, is a pretty rare problem. Pretty rare because most of the time when our blood glucose is low, we release glucagon, cortisol, epinephrine, and growth hormone, and those help bring our blood glucose back up towards normal. Some of those hormones like cortisol and epinephrine may signal to the brain and cause you to feel stressed out or jittery or even sweaty. And hopefully that signals you that it's time to eat, and you go eat and bring your blood glucose up even higher. So we don't really have to worry too much about hypoglycemia normally, but actually it might surprise you that people with diabetes actually have to worry a lot about hypoglycemia. Diabetes are people with hyperglycemia, so again, let's see why we would have to worry about hypoglycemia. So most people with diabetes are taking some sort of medication or maybe injecting themselves with insulin in order to bring their blood glucose back down to normal. So they might time that in the morning or at night or during or after meals, but they're doing the job of their pancreas to keep their blood glucose low. But sometimes things can go wrong. So imagine if you injected yourself with the wrong dose of insulin, or maybe you took insulin but forgot to eat a meal, or perhaps you just took too much medication. In those cases, the hypoglycemia or low blood glucose from that can actually be very severe and dangerous. So the next learning objective, we're going to change gears a little bit and talk about this concept of energy homeostasis and weight stability. And it really relates to homeostasis of our fat energy stores and also our body weight. So our brain's pretty obsessed with homeostasis, but couldn't the brain regulate our body weight and our body fat? So again, if you think about your body weight, and if you want to keep your body weight stable, you've got to balance calories and your energy expenditure. If you have more food intake, then you'll gain weight. If you have an increased metabolic rate in physical activity, you'll decrease your body weight, and some sort of balance between them will keep you at a steady body weight. And if there's a set point for your body weight, homeostasis would mean that if you increase your fat stores and body weight, there would be some signals in your body to bring your body weight back down towards a set point. Also, if you ever lost weight and decreased your fat stores, then there would be some other signals that would cause your body weight to go back up towards its set point. So there actually is some evidence that the body regulates body weight and energy stores, or fat and adipose tissue levels. So is there stability in our body weight? So one interesting study showed a group of people that had a stable body weight. They studied their baseline caloric intake, and so just to keep their body weight stable. And then they put them on a caloric restriction diet. So they let them eat less calories, and they lost about 8 or 9 pounds. And then they put them back on their baseline diet, and you'd assume that then they would just maintain that 8 pounds of weight loss. But instead, when they put them back on their baseline calorie level, they actually gained weight, and they actually went back to their normal body weight, so their weight set point. In the same study, they took these same people and had them overeat, so they actually ate more calories than normal, and of course they gained weight. They gained 5 or 6 pounds. And then they put them back on their baseline calories, and you'd suppose that then they would just have a stable new weight with that gained 5 pounds. But instead, once they put them on their baseline diet, they actually lost weight, and they went back down towards their normal sort of original starting weight. So this sort of suggests that our body weight is regulated around some set point. The next learning objective is describe the role of hormones in weight regulation. The two hormones we'll study are leptin and ghrelin. Other hormones affect body weight like T3 and T4 from the thyroid, cortisol and epinephrine from the adrenal glands, even growth hormone and brown fat. In the 1940s, they discovered these little mice that became spontaneously obese. Many years later, when they studied the genetics of these mice, they discovered that they had a genetic mutation that didn't allow them to make a protein called leptin. So the obese mice couldn't make leptin, and they couldn't regulate their body weight. Normal mice made leptin and always stayed lean. So it turned out that they discovered this hormone or protein called leptin, which seems to regulate body weight. It turns out that leptin is made by adipocytes in our fat tissue, and the more fat we have, the more leptin we make. Leptin's a hormone, and it travels around our body, and one of the targets of leptin are neurons in the hypothalamus. So when we have more fat, we make more leptin. Leptin then signals to those hypothalamic neurons so that we decrease feeding and we increase our metabolism, which should then bring our fat stores back down to a lower level. Again, thinking of homeostasis. So it turns out that leptin depends on how much fat you have. The more fat you have, the more leptin you make. The less fat you have, the less leptin you make. So again, when we have more fat, we make more leptin. That leptin then targets our brain to decrease our feeding or increase satiety and decrease our body weight. And then we lose our fat and the leptin levels go back down. So again, that looks a lot like homeostasis. What about if you have really low fat levels and low body weight and you haven't eaten in a long time? You won't have much leptin and you'll actually get ghrelin secretion, a hormone from the stomach. So when you haven't eaten in a while, you'll produce lots and lots of ghrelin. Ghrelin then targets similar areas in the hypothalamus, increases your feeding behavior, increases your hunger, and decreases your metabolism, which should then act to bring your body weight up. So ghrelin actually acts the opposite of leptin and stimulates feeding and decreases metabolism and should bring body weight back up. So these hormones suggest that we actually do have body weight and fat storage regulation. So leptin stimulates satiety or less feeding, and ghrelin stimulates hunger or more feeding. And so these should then hopefully bring your body weight back towards some set point. Both of them target the hypothalamus. So these hormones are released throughout the body and they have a lot of effects, but the effects we're going to focus on are these brain pathways and neurotransmitter pathways in your brain, in your hypothalamus, whether you feel hungry or maybe you feel satiety or full. So leptin, when it actually makes its way up to your hypothalamus, stimulates little neurons, and those neurons then release a neurotransmitter, a very powerful brain chemical called melanocortin. So melanocortin actually then triggers and has a lot of those effects, such as satiety, not eating as much, and causing weight loss. On the other hand, ghrelin targets a different set of neurons, and those neurons then release brain chemicals such as neuropeptide Y and endocannabinoids. Endocannabinoids are actually the same as the active ingredient in marijuana called cannabinoids. So these are going to increase your hunger, increase feeding, and lead to weight gain. So what if you really just want to eat, besides your leptin and your ghrelin signaling? Well, we have reward pathways which can spike our dopamine, and so those reward pathways are probably powerful enough to override the leptin and ghrelin signaling in the brain. So it seems like we might have a weight set point, and that when we lose weight, our leptin levels will actually be very low, our ghrelin levels will spike, our T3 and T4 will actually become low, and those hormonal changes then should stimulate us to gain weight, either to decrease our metabolism and increase our feeding. What about when we gain weight? When we gain weight, we'll have more fat, so we have high leptin and we have low ghrelin. Again, those hormonal changes should cause us then to lose weight because we'll do less feeding. So you might wonder if maybe people who are overweight are leptin deficient. Well, actually they make lots of leptin, and studies suggest that perhaps they're leptin resistant. So their body doesn't respond to leptin, and so that's why they keep the weight on and do not lose the weight. So is leptin working? Well, some people suggest that maybe when we're overweight we have leptin resistance. Just like in diabetes we have insulin resistance. So if we have these hormones and we have weight regulation, then why do we have obesity? Well, one thing that's important to note is that many animal models and many humans actually have very stable body weights over the course of their lives. So this would suggest that body weight is actually regulated and should be very stable. There's also the possibility that people have evolved to survive periods of famine rather than overabundance. So maybe the body isn't used to gaining lots of weight, and so that these signals aren't very good at causing us to lose weight. Right? Once you gain those calories, you're waiting for the next famine when you'll need all that body weight. It's possible to speculate that maybe the leptin and ghrelin pathways actually make it easier for us to defend against weight loss rather than to defend against weight gain. So we sort of have a stronger signal and stronger pathway to cause us to gain weight rather than lose weight. So if we look at that study where we looked at the weight loss and weight gain, when we lose weight, ghrelin levels rise and leptin levels go down, which brings us back to our set point. When we gain weight, we have higher leptin and lower ghrelin, which again bring us back down towards our set point. So there seems to be some ability for us to regulate our body weight around a set point. There's also the possibility that over the years our set point shifts upwards, and maybe that's why we continue to gain weight. All right, that's it. I will see you guys in class.